Okay, good morning, everybody. Today is March the 10th, and welcome to today's Infectious Disease Echo. Just a couple of things. We are recording. Um, we also are offering continuing education credits for medical and nursing. And Anna will be sharing that link uh, right there in the chat box. Please fill out the survey. You have to attend the entire session for it to count. And there's no financial disclosures. And if you will put in your name, tribal affiliation, and position in the chat box so we can take attendance. And I know before we begin, Gabby, where's she at? There you
Hello.
are. Gabby has a slide she wants to share.
Give me just one moment. Do I have rights? Yeah.
Mhm.
Okay. Can you guys see that big or is it still?
It's not a pres it's big. It's
No.
big enough. Yeah, there you go.
Okay, cool. Does that make it bigger?
Yes.
Okay. So let me one second. Oh, that's gracious. Why is it not working on my paper? Okay, so hello everyone. Sorry about that technical difficulties. I hope everyone's doing well this morning or afternoon. My name is Gabby Niski. I am the Infectious Disease Program Manager, and I just wanted to highlight something that you may have seen in your emails of the infectious disease clinical training that we have going on that's focusing on hepatitis C, HIV, and PrEP and substance use disorders clinical training. This clinical training will be taking place in Portland, Maine, and will be at the Westin Portland Harborview. If you have not registered yet and you are wanting to view or get a slot into that hotel, I believe the closing for that out is at the end of this month, correct,
It's the
Brian?
end of next week.
And the end of next week. Okay, so it's on the 26th, I believe is next week. Um, and then it is from April 11th to April 13th, will be happening every day from 9 a.m. to 4 p.m. And we invite those who should attend as a USET member tribal nation, health directors, clinical staff, physicians, nurses, case managers, and anyone supporting tribal nation citizens through the health sector are welcome to join. The learning objectives that we will be focusing within this training are the importance of universal screening, examining the epidemiology and prevalence of hepatitis C, HIV, and substance use disorders, the newest hepatitis C and HIV antiviral treatments, substance use disorders medicated assistant treatments, as well as best practices in Indian country and teleconferencing mentoring system. I will be providing the draft agenda in the chat box as well as a registration if you would like to attend. Again, the registration for the hotel is the end of this month, so make sure you get your slot in if you're wanting to attend, and we hope to see you there.
Just to clarify, I misspoke. It's not the end of next week, it's the end of the week after that. So the 24th is the cutoff for the hotel.
Okay, so March 24th is the cutoff.
Yep.
Okay, great. Does anyone have any questions? Brian is the lead in this, so if you do have any further questions, you're more than welcome to email me or himself.
Okay. Anna, do you want to go ahead and get started?
Yeah, I'm gonna go ahead and share my screen here. All right, can everyone see that okay?
Yes.
All right, so we're just gonna go ahead and start off with our epi update. First, we're gonna go ahead and talk about COVID-19 within the USET region. So I do have the data sources here that we have been using. Yay, update. We did get our access to HHS Protect back. So we do have some additional data here that we haven't been sharing for the past 3 months. So just a general overview. This was the report from February, and now we have the one from March. So as you can see here, we do have this similar variant still going around. We have XBB.1.5 still as the primary variant within the region. For the USET purchased and referred care delivery areas, we have seen a decrease from 187 to 143 patients hospitalized with COVID-19. And this decrease did also was seen throughout the USET states as well by about 200 or so. For the total number of positive COVID-19 test results, we did have a slight decrease from February to March. Now we're sitting at around 97. We have seen the 7-day positivity rate increase from 12.7 to 17%. I hypothesize that's likely just due to a decreased number of tests run, just kind of making those that are positive kind of increase that rate a little bit, but we are seeing some downward trends in the numbers of people with COVID-19 and those hospitalized with it. So the variants, as we just kind of discussed, we are seeing in this kind of purplish color, XBB.1.5. It has been steadily increasing over the weeks and throughout our region. We are seeing BQ1.1 kind of holding steady here, but just slightly decreasing. And we are expecting XBB.1.5 to continue as kind of the primary variant for now. Just showing all of the regions across the United States. This is by HHS region. So over here in the USET area, like I was just saying, we are seeing that high prevalence of XBB.1.5. For the COVID-19 community levels within the USET states, this is February, this is March. So we are seeing higher rates of this low community level within our region. We do have a little bit kind of greater medium COVID level up here in the Northeast region, but only just a few high counties sprinkled throughout. Just for the overall United States, this is from February and this is March. So we are seeing this trend kind of just spreading throughout the United States with a kind of over 80% of the counties being at a low community level, and a kind of positive change in that direction as well. For the national wastewater surveillance, this was from the February report, and this is March. We are still seeing a very high percentage of wastewater samples with that detectable COVID-19. That's not all too surprising. This is kind of a early warning system, but like we discussed on previous calls, the data is aggregated and likely it will stay high as we have kind of just coronavirus throughout the wastewater. For COVID-19 hospital admissions, we have February and then March. So we have been seeing a decrease from the USET PERTA, the USET states, and the United States as a whole. The United States as a whole, we have decreased by about 200 hospital admissions per 10,000. USET states is following that trend as well, and then the USET PERTA is down to about 143 from about 187. So this is the percentage of total inpatient hospital beds used. This is the data from HHS Protect that we did not have access to from December, January, and then February. March of, well, right now, I guess we did get our new HHS Protect access back, which is why we have only the data points for October, November, and then March. As the months go on, we are planning on kind of condensing this graph into just the past 3 months, but I thought it was important to kind of show the trend. For the USET PERTA in yellow in the United States as a whole, we can see this kind of similar trend going on, kind of hovering around 80%, but decreasing. For the USET states, we do see we are over 100%. That is because some of the hospitals have a capacity of 0, and they are reporting that they have inpatients in their hospital beds. So I wouldn't worry too much about this right now. We'll kind of see what the trend does in the next few months, but I would mainly focus within the USET PERCTA for this metric this month. For COVID-19 vaccination data, so we are kind of steadily hovering around the same percentages we have been at around 55.3%. The percentage of the population fully vaccinated, that is with the people with their primary series, so those 2 doses, not including the bivalent vaccine. We see reporting facilities within IHS at about 55% compared to the United States, which is at about 69%, and then IHS as a whole at about 44%. So the number of additional doses administered, we do only have a little over 21% of our population with that additional bivalent booster dose as well. This is the percentage of population fully vaccinated or those with their primary series. Like I said, we're comparing this Nashville area IHS percentage to the United States and then all of the USET states within the region. The percentage of population fully vaccinated with the bivalent booster dose, we are seeing this percentage is significantly lower. We're hovering at about 20%. So we're just kind of seeing the differences throughout the states on that vaccination rate. We have our data sources linked here for those that are publicly available. I did just want to again mention that we do have the COVID-19 national emergency and the public health emergency set to expire on May 11th. We are planning on coming out with a series of alerts addressing all of the specific changes to address this in the coming weeks. If you do have any specific questions about this, you can feel free to put them in the chat and we'll make sure that we either address them here or within that alert series for you. So now moving on to the influenza update. We have been doing a bi-weekly report that has been sent in a alert format on Wednesday. We have our data sources linked here. So just some general information, this is just to provide a general overview of influenza across the United States within IHS and then specifically within the Nashville region. And this whole report is based around the MMWR week, which is the morbidity and mortality weekly report. So for example, week 1 would start on January 1st and then go kind of down through there. For influenza-like illness, I always like to make the distinction that it is for a respiratory illness, including fever plus a cough or sore throat, and it is not laboratory confirmed influenza. So this is the report from the MMWR week 8, which is from February 19th through the 25th. So over here in this column, we have the percentages of the influenza positive tests reported to CDC. We see that is hovering at around 1%, which is just a slight decrease from the week prior. The weighted percentage of ILI visits is still hovering around 2.6%, and that has not changed from the previous week. We have seen a decrease in the number of new influenza hospital admissions. This number is at around 1,500. And then comparing the percentage of ILI visits for IHS within the United States is at about 1% and a slight decrease from the previous week. For the Nashville area, we are a little bit higher than that at 1.9%, and we have seen a 0.1% increase from the prior week. So up here at the top on the left, this is a map of the United States, and each state is color coded with the ILI activity. We see here a general trend of low level influenza throughout. So a lot of these states are in level 1 through 4. We do just have some reaching up to level 9 and then level 8. So just general trends. We're kind of leveling off here with the influenza. Down here in the bottom right, we have the percentage of outpatient visits for respiratory illness. We can see here the 2022 to 2023 season is this black line with the red triangles. as we previously talked about, we had a very high peak of influenza earlier than usual. And now we have since kind of leveled off and we're returning to this 2022-2023 national baseline. We do have the other seasons on here in various colors, as you can see there, just to show kind of a comparison in between the seasons. For vaccination on the left here, this is by the IHS region. Nationally, for seasonal influenza vaccines, we're at 29.4%. For the Nashville area, we're a little bit higher than that at 32.5%. On the right for age groups, for the Nashville area, we can see those 65 and older are leading the way, 58%, followed by adults, which are those 18 to 64 years old at 35%, and then children, so 6 months to 17 years at 26%. And we are just seeing some just slight increases week to week with those numbers. The number of new hospital admissions by HHS Protect region. So we have the total United States here in this red line. We can see we had that high peak and now we've kind of come back down and leveled off. We're well below 5,000. And then we can see all of the other regions in their specific color. And I will mention these are only regions within the USET area, so not all of them. But we can see here they're kind of leveling off and lowering as well. And then if you have any questions, feel free to ask them now or put them in the chat, or you can always email us as well.
Thank you, Anna. Do we have any questions at this time?
I have a comment. So congratulations. That was a really good presentation. Appreciate all the data. No, since you were talking about influenza, so I don't know if you've heard, it was last week that the FDA approved a home test for influenza, and I believe it's influenza A, B, and COVID combined, which I think it's a great game changer. You know, during the COVID pandemic, I've always wondered, we have all these good tests, and we still don't have a home test for influenza, and you really have a shorter window of treatment for influenza. So I think it'd be interesting. If I'm going to talk to other tribes, we should try to implement like a test and treat for when the influenza comes. So now we're hopefully out of the woods, like you mentioned on your graph. But then for the next epidemic, it would be very good to have a system in place that the patients can have access to these kits, test themselves. When they're positive, call a provider, get a telemedicine visit or a telephone visit. And you prescribe the antiviral immediately, or have the pharmacist do it like they're doing it with COVID. But I think if we are proactive in this, it's really not going to happen unless we see the CDC pushing something like this. But they take a little bit longer to come up with these recommendations because they need a lot of data and all that stuff, all that good stuff like data. So that's one thing. And the other thing is that also FDA approved an RSV vaccine for older individuals. So I think we have also take a look at that. Maybe Harry would want to update that on that as soon and see when it's going to be available and how we implement that. And thank you, Anna. It was a great talk. And if you can send me your slides, I'd appreciate that. I need to use some of them.
Okay, if there's no other questions, we can move on to Dr. Mara's presentation.
Okay, let me share my screen. Okay, can you see it correctly?
Yes.
Okay, when Brian asked me to give a talk on HIV, I'm sorry, let me try to eliminate this simultaneous. Oh, I don't know how to eliminate that. Okay, you have to watch the translation below. Sometimes it gives a weird translation with my pronunciation, but disregard that. So when Brian asked me to give this presentation, and it was 30 minutes, I said, it's a big topic to crunch it, and let's split it in two. So this is the outline of the two presentations. And so I'm going to walk you through memory lane a little bit. I have the advantage of being old, and I was practicing medicine when the HIV, I was a medical student actually in my last year when the HIV epidemic started, and I was a resident when we had the big surge of AIDS in the hospitals. Then we'll talk a little bit about epidemiology and HIV transmission, life cycle, and impact on the immune system. And then I'll stop there. And on the next presentation, I'm not sure when that will be, we'll talk about opportunistic infections, diagnosis and management, and prevention. So as you all know, HIV is human immunodeficiency virus. And on the right, you see an electronic photograph that was actually taken by the Luc de Montagnier's group in France in 1984 and sent to the NIH. And I'll give you a little bit more of that history, which is interesting. And they found the retrovirus, which is here, attaching to a CD4 cell. And I'll tell you a little bit about that history, which is also pretty fascinating. So what the virus does is it infects mainly our CD4 cells. It does infect other cells also, but that's the main target. And it just ends up destroying the cells. And these cells are very important for your immune system. And that's why people, when they're infected and they're not treated, they end up with opportunistic infections and opportunistic tumors, if you may. So this epidemic started in the United States in 1981. It started a long time before in Africa, but it was not detected in that continent. So in 1981, you see several reports of gay men being admitted to the hospital with Pneumocystis jirovecii pneumonia. Before it was called Pneumocystis carinii, which is a fungus. It's a weird fungus. And this pathogen usually affects people with severe immune deficiency. So it was a little bit puzzling because these patients did not have any history of an immune deficiency, but they were behaving as if they were immune deficient. And you see cases reported in New York and cases reported in California initially. And as the epidemic started evolving, it was detected that it was not only MSM, but also people who injected drugs, also the Haitian population and patients with hemophilia. And that's what started thinking that this could be a bloodborne transmission. But it took, from the first case detected in 1981 in the US, it took 4 years until the virus was identified. A little bit different than what happened with COVID. It was detected in about a month right after. And that just shows you that science has evolved and technology has evolved. So in 1984, Robert Gallo received this photograph from the French, and not sure what happened there, but it was published as they had found it. And there was a big litigation, like who actually discovered HIV. And the litigation was important for an economic purpose, because whoever claimed or got the patent of this finding could patent the serology kits for diagnosis. And that was a multi-billion-dollar business. So it took actually Mitterrand, the president of France at that time, meeting with Ronald Reagan to solve this problem. And they ended up dividing 50% glory for the French and 50% glory for the Americans, so they could share the patent. Nevertheless, when the Nobel Prize was given for this discovery, it was given to the French. So you can make up your own conclusions of who found the virus or not. So in 1985, that we had the first commercial test available. And I will tell you, and the people who are my age and were experiencing this epidemic back then, it was pretty scary because we knew we had this virus circulating. We knew that there were people with risk factors, but we also see individuals that didn't meet those risk factors, like being men having sex with men or injection drug users, etc., that caught the infection. And the transmission was not very clear at that time, but it seemed to be bloodborne transmission. In 1987, we had the first antiviral, which is AZT. Basically, what it did, it prolonged the life of individuals by 6 or 8 months, because then the virus would continue to replicate. But letting you know that we couldn't even measure the virus. We could only measure the antibodies and say a patient has HIV, but we couldn't measure the viral load and know about the impact. And as you can see here on the right, there's a graph that shows proportions of patients surviving months after the opportunistic infection was diagnosed, because they usually would present with an opportunistic infection. And the majority of individuals were dead by 10 months after the first opportunistic infection. And here you see a photograph of Ryan White, which was a young kid with hemophilia who suffered a lot of discrimination in school because he had AIDS. And it's a long, interesting story, but it turned out with kind of a happy ending that Congress passed the Ryan White Act, giving a budget to support people living with HIV and people with AIDS. And unfortunately, this young kid died of AIDS complications at a young age. So as time went by, 1994, 1995 was a critical year because that's when the first antiretrovirals that included protease inhibitors were discovered. And the first one was ritonavir. And then came a long list of them that we will briefly touch on my next presentation. But on the right, you see a photograph of David Ho, who was the pioneer in the development of this drug and also of the pharmacodynamics of this antivirals with the virus. And there was a very exciting times because, just to give you an idea, in 1994, at least where I worked in Argentina, half of the hospital beds were occupied by patients with AIDS. And after 1995, we barely had any patients with AIDS admitted because we started them on these protease inhibitors, and we caught them on time. They would recover and started having a normal life, not needing so many hospital admissions. And in 1995, 1996, this is 14 years after the epidemic was discovered, we could measure the virus in blood, and we had a viral load to follow treatments. So from 1997 to 2000, first there was a little bit of excitement. It was thought that you could actually cure HIV with treating the patients with antivirals for several years. The mortality decreased significantly. You can see here on the graph on the right, in 1995, 1996, that was the peak of mortality of deaths per 100 person years. And then it plunges, it declines, and that's because of the use of antiretroviral therapy. The guidelines, initially, we would treat patients with certain CD4 levels, but then it was treat early and use a combination of drugs. But it was also found that it was not possible to cure HIV, and I'll show you in the next few slides why. But you could suppress the virus and people would recover their immune system and could lead a quasi-normal life. So it was 1998, 2000 that we realized, okay, it's not possible to cure because there's a reservoir of viruses that the antiretroviral treatment cannot reach. And also in that year, there was an important AIDS conference in South Africa, which I was lucky to attend. And it was the shift in paradigm that until the whole world didn't have access to antiretrovirals, we would not be able to even grasp controlling this epidemic. And that's when all these the programs from US and Europe started supporting patients around the world, including Africa, which was the center of the epidemic with HIV antiretrovirals. As time went by, originally most of our patients would have to take 20 to 30 pills a day. It was the different combinations. And now, as you well know, we are down to 1 pill a day that contains 3 different drugs or 2 different drugs. And the treatment is much simpler and much less toxic than it was 10 or 15 years ago. Unfortunately, vaccines have not been successful so far. We still have hope, especially with the new technology that has risen with the COVID pandemic. And in 2010, there was a case called the Berlin patient, which was a German patient that was cured from HIV. And it was a very interesting story if you haven't read it. This patient had leukemia, and the bone marrow transplant doctor that was going to do the bone marrow transplant, he thought, well, maybe if we choose a donor that does not have CCR5 receptors, and we'll talk a little bit about that probably in our next talk. So the virus, actually in this talk, the virus needs a CD4 receptor to infect the CD4 cell, but also needs CCR5 receptors to bind to the cell surface. Some people don't have these receptors. It's less than 1% of the population. But if you don't have these receptors, you don't get infected. And we have time, I'll tell you how that was found. But the bottom line is that this doctor said, if I find a bone marrow donor that does not have CCR5 receptors, maybe we can cure this patient of HIV because the virus won't have a place to anchor itself. And that's what he did. He transplanted the patient with a CCR5 negative receptor patient, and the patient was cured. And then there was also several patients like this in the United States that were cured through bone marrow transplantation. Of course, this is conceptually very interesting, but it is not feasible to use this as a treatment technique since the mortality due to bone marrow transplant would surpass, and the costs would surpass what we can achieve with antiviral medication. So as time went by and people got better treatment, less toxic treatments, mortality declined significantly. And although it is not the life expectancy of an HIV individual is not exactly the same as an HIV negative individual, it is very close. And especially if they get good health care regarding other risk factors that drive mortality in patients with HIV today, which is not the virus itself, it's more cardiovascular complications. So in summary, in the last, since 1981 that the virus was discovered until 2020, we were able to identify the virus, a diagnostic test, measure the viral load, learn a lot about antiretrovirals, and end up with very simple treatments that make it possible to end the HIV epidemic if we implement other things, which we'll cover at the end. Also here, it's important that during these trials of testing these drugs, it was found that people who were suppressed with HIV did not transmit the infection. So that's where the U equals U, or undetectable equals untransmissible concept came about. Let's talk a little bit about the epidemiology. And I'll just share a few slides, mainly from CDC. This is a slide that shows new HIV diagnosis, or an incidence slide, if you may, in the United States. And you can basically see that the greener the color, the higher the incidence. That in the United States, the Southwest area is the most affected with acute HIV infections or newly diagnosed patients, which is not the same thing, but it kind of correlates. When we look at prevalence, again, you can see that usually the Southwest and California are the states which have the higher number of people with diagnosed HIV in those areas. And when you look at mortality, it's not surprising that, again, in the southwestern part of the United States, one of the states that I work in, Oklahoma, it is strongly affected by mortality is higher in those states. And the reason it's a little bit complex, it's not just one factor, but access to, diagnosis and access to healthcare is important. So let's talk a little bit about new infections and Native Americans. So in 2019, there were 34,800 estimated new HIV infections. And here, based on this population-based study, you can see the number of individuals infected. Of course, Native Americans, the absolute number is low because the population is much lower. But the trends are a little bit scary because when you look at trends of HIV stratified by race and ethnicity, you can see that most of the other ethnic groups or racial groups either are decreasing or stable, but in the Native American population, there was a slight increase of 22% of HIV diagnosis. And the really scary part is when you look at risk factors for transmission in the general population, the group that's at highest risk is men who have sex with men, and then comes individuals who inject drugs and have sex with men at the same time. And then you have heterosexual contact and injection drug use. But when you look at females in Native American population, 43% of Native American females who have HIV, the way they acquired it is through injection drug use, which is 4 or 5 times higher than the general population risk of acquiring HIV through injection drug use. So there is a lot of work to be done to mitigate this problem. And again, the reasons are complex and multifactorial. But one factor is lack of syringe service programs in areas where Native Americans reside. Just one of many factors. So here on this graph, you can see HIV in the United States by race and ethnicity. So as in 2019, there were in total in the United States, there were 1.1 million people living with HIV. And for every 100 people living with HIV, 87 knew their status. But when you look at Native Americans, only 80 knew their status. And it's compared to other ethnic groups, is the group that has that needs more active work in trying to, for us to screen and make sure the population is aware of the risk factors and they get screened. Universal screening as a rule, but if they have a risk factor, to get screened more frequent. And in this graph, it's the injection behaviors among people who inject drugs in 23 US cities, also stratified by race and ethnicity. And overall, 1/3 of people who inject drug without HIV use a syringe after someone else used it. And more than half, 60% of people who inject drugs without HIV used an injection equipment after someone else used it in the past 12 months. And here you can see the graphs. I just highlighted the Native American part of the graph. So 29% of people who inject drugs that do not have HIV use a syringe from someone else, and 61% of Native Americans also share the equipment with other people. So there's a lot of work to be done here in educating not only educating, but providing the population who injects drugs with services that can mitigate them sharing syringes or paraphernalia with other people. And this graph shows people with diagnosed HIV in 44 states by race and ethnicity, and there's several factors that are being evaluated. If they received some HIV care, if they were retained in care, or if they were virally suppressed. And at the end of the day, the most important thing is virally suppressed. It doesn't really matter if you're retained 100% in care and you're virally suppressed as 20%, because what will improve the quality of life of that individual is viral suppression, and what will decrease the risk of transmission is viral suppression. So when you look here at Native Americans, which is the first column, compared to other ethnic groups, Native Americans and African Americans have the lowest rates of viral suppression. And that also is multifactorial and beyond the scope of this lecture, but it just highlights that we need to improve our screening programs. We need to improve engagement in care, retention in care, and make sure that all our patients who are HIV positive know they're HIV positive and have access to antiretroviral drugs. So in summary of this part, mortality peaked in 1994 through 1995, and then it decreased dramatically, and then it's still decreasing, but it's kind of plateauing, especially in the Southwest, and that's where more interventions need to be done. And overall, in the United States, persons dying of HIV mostly are males, African Americans, reside in the South, and are 45 years or older. And HIV continues to be a leading cause of death among people ages 25 to 44 years old in the United States. It's the number 12. It used to be number 1 and 2, but now it's down, but it's still high. So all of this information that I gave you is what triggered the End the HIV Epidemic movement and programs. And they were driven because of all the lives that have been lost. Over 700,000, this is data from 2 or 3 years ago, have died from HIV/AIDS in the United States. $20 billion a year are spent in HIV care. And if we don't do any interventions, 400,000 Americans will be infected with HIV in the next 10 years, because it's about 38,000 per year. And that is a lot of people getting HIV, a lot of people getting sick, and also very expensive for society. And the important thing is that 87% of new HIV infections are transmitted from people who do not know they have HIV. And that's another important reason why we need to improve our the knowledge of status of HIV of the individuals, because when they know they have HIV, they take care to not transmit the infections to other people. But if they don't know they have it, they may be a little bit careless with their sexual behavior or with their injection drugs use behavior. So this was why 2 or 3 years ago, the CDC came up with a plan based on targeting counties or states that had high prevalence, high incidence of HIV. And you can see in the light blue are the southwestern states that I highlighted on the other graphs. And then the dark blue are just counties across the United States that have a very high incidence of HIV. And that's where the major efforts were deployed in the last few years. Efforts regarding prevention, diagnosis, prevention, and treatment. So the 4 pillars of ending the HIV epidemic in the US is to diagnose, everybody who has HIV should have a diagnosis. Everybody who has HIV should be offered a treatment and try to retain them in care and achieve viral suppression, which is the main goal. And also, there has been a lot of resources for putting patients at high risk of HIV with medications with pre-exposure prophylaxis to decrease the transmission of HIV. And finally, this is us as providers, we are involved in those 3 first steps: diagnosing, treating, and preventing through education or through HIV PrEP. And then the health department takes the responsibility of trying to detect outbreaks and respond quickly to these outbreaks to mitigate them as much as possible. So we'll talk a little bit about the life cycle and a little bit about the immune system, and we'll stop there. But just a few concepts that are important. So the HIV viral load is just the quantity of viral particles that an individual who's HIV positive has in its blood. And it's an important parameter to monitor the efficacy of treatment. And in general, the higher the viral load, the faster the CD4 cells are going to be destroyed, and the faster the patient will progress from just being HIV positive to having AIDS. The CD4 count is just a measure of the absolute T cell force, CD4 T lymphocytes in the blood per ml of blood. And patients have acquired immune deficiency syndrome or AIDS if they have developed an opportunistic infection or if they have a cancer that is associated with HIV. Another definition that actually was placed in the 1980s, more for social reasons than anything else, is a CD4 cell count of less than 200 or a CD4 percentage of less than 14, regardless of if the patient had an opportunistic infection or not, or an opportunistic tumor. They would be identified as individuals with AIDS, but that was done so they could get better social and health coverage with that diagnosis. As far as I know, it still applies, but I just wanted to clarify that this was just introduced to get more people under care. And antiretrovirals, you can, today we use ART, antiretroviral therapy. In the past, we would use HART, which is highly active antiretroviral therapy. And the patients, when they had to take 20 pills a day, they usually mention that as the cocktail. That term has gone away because now we treat them with 1 pill a day and 1 or 2 pills a day at most. And they are fine with that. So the way HIV is transmitted is through the exposure of certain body fluids, which is usually blood, semen, pre-seminal fluid, rectal fluids, vaginal fluids, or breast milk, if those fluids are in contact with a mucosal membrane or damaged skin, for example, in the case of a needle stick injury or in the case of someone who's injecting drugs. It is important to explain to patients, and now especially patients, because they're very scared of transmitting the infections to other people. And the most important thing is to virally suppress them, because if they're virally suppressed, they cannot transmit HIV. But if they're not virally suppressed, it's also important to tell them that you will not transmit the infection by sharing utensils, by saliva, unless the saliva has blood in it for whatever reason, through tears, sweat, shaking hands, by breathing, sitting in sharing a toilet with someone else, closed mouth kissing, hugging, or mosquito bites. So I'll tell you a quick anecdote. 1984, I was a resident in Buenos Aires, Argentina, full-blown AIDS epidemic. Our call room was close to the patient's rooms. We did not know that we didn't have an HIV test, and we were not sure how this was not transmitted. Every time I was on call and our floors were full of AIDS patients and a mosquito was flying over me, I would cover myself from head to toes because I wasn't sure it couldn't be transmitted by mosquitoes at that time. We finally knew it couldn't, and that gave us a little bit of relief. But when I think about those fears that we had, it's interesting. So the way that the highest risk for acquiring HIV is through receptive anal intercourse. Now in this graph, in this table, I'm sorry, you can see per 10,000 exposures, what is the risk? So if you have 10,000 exposures or 10,000 encounters with receptive anal intercourse, 138 out of this 10,000 exposures can end up in an HIV transmission. The highest risk would be if you receive a blood transfusion from an HIV-infected patient and the blood has not been checked, which this doesn't happen anymore. But or the risk is extremely low, it'd be like 1 in a million. But before we had a test and before we knew blood was a main mode of transmission, a lot of people got infected through blood transfusions in the late 1970s and early 1980s. And you remember a lot of famous actors like Rock Hudson. He got and this famous tennis player, I can't remember the name right now. They had a cabbage done and had a blood transfusion, and that's how they got HIV. And of course, people who had hemophilia, unfortunately, the majority got HIV in that period of time. And here you have the other risk factors. So insertive anal intercourse is less risky. Still, there is a risk. Receptor penile vaginal intercourse, a little bit less, and so on and so forth. Then there's other potentially possible ways of transmitting it, but it's negligible because there's not really good documentation, like biting someone or spitting or sharing sex toys, etc. There's no good documentation that that's a way of transmission, but hypothetically, it is possible. So the HIV virus is depicted here, this cartoon, and the virus has a P24 antigen that sticks into the CCR5 and then CCR4 receptors, and it's internalized into the cell. And then the RNA, through a reverse transcriptase, is transformed into DNA. And that's where many of the antiretrovirals that we use work, like tenofovir, for example. And then the virus needs to be integrated into the human DNA, and that's done by an enzyme called an integrase. That's another place where a lot of our main antiretroviral medications that we use today work, like integrase inhibitors, like bictegravir, for example, or dolutegravir are integrase inhibitors. And then the virus assembles. The DNA is transcribed. It produces through the ribosomes all the proteins needed. It assembles, and before this can happen, it needs a protease to slice the polyprotein into different components of the virus, and that's where the protease inhibitors work. And then the virus gets out of the cell and infects other cells, and that's kind of less the cycle. And on the left, you have all these steps that I've mentioned. So why we cannot cure HIV? And for example, why can't we cure hepatitis C? Because hepatitis C is not integrated into the human DNA, and it's only in the cytoplasm. And that's why we can cure hepatitis C with 2-month antiviral treatment. But this proviral DNA that is integrated into the human DNA, the antiretroviral drugs do not act in this place because unless the virus starts replicating. But this is the reason that we cannot cure HIV with antiviral drugs, at least not yet. There's a lot of research going on to see if we can expose this DNA in some way or form and be able to cure it, but that has not happened yet. So as this is the HIV viral load in CD4 over time. So at the beginning, the red dotted lines is the viral load. You get infected, you have a very high viral load. Then it comes down a little bit, and it's stable for a while, and then it starts to increase again. This is without treatment. And the CD4 cell counts, there's a little blip, a little decrease initially, then it stabilizes, but it progressively decreases with time, and it gets to a point in which it gets below 200. That's where the patients start getting the opportunistic infection. So it does not mean that if you have 300 CD4 count, you don't get opportunistic infections, but the majority of patients start experiencing these infections when the CD4 drops below 200. Now, this takes some time, and for some patients, it's variable. In general, the average, it's about 4 to 5 years from the day you get infected until your CD4 drops below 200, and you get these infections or opportunistic tumors. But some people do it much faster. And then there are a group of people that they were called elite responders, that they control the virus very well, and they can live 20 years with good CD4 cell counts and low viral loads. But these are the minority. So when you get infected, there's no symptoms. After a few years, 4 or 5 years, I would say you start with experiencing weight loss. You might start getting some infections in your skin, candida infections that you would get, oral thrush. And after a little bit more years, you start getting all the complications that I'll list them to you in the next slide. That will then finally, end up killing the patient if they're not started on antiretroviral treatment, and if they're not started on the opportunistic infection treatment. So in this slide here, you can see the CD4 cell count and what are you at risk with those counts. So if your CD4 is above 500, you're basically out of the woods except for tuberculosis. So if you got infected with TB, you still have a higher risk of developing active TB if you're HIV positive, even with a high CD4 cell count. When your CD4 is between 200 and 500, what you will see, you add things here. You start seeing people with oral thrush. When they drop below 200, besides the TB and the oral thrush, now you can get esophagitis due to candida, and you're at risk for pneumocystis, PJP pneumonia. When it drops below 100, you add Mycobacterium avium infections, cryptococcal infection, histoplasma, and tumors, lymphomas. And when it's less than 50, you are at risk for cytomegalovirus retinitis, and of course, lymphomas and also anal cancer, etc. So here there's just a cartoon of different infections and the organs that you get it. So I'll stop there, and on the next lecture, we'll cover more details on diagnosis and also a little bit deeper dive on opportunistic infections, since unfortunately we are seeing them more frequently. So in the last year and a half, we've seen several patients that show up with cryptococcal meningitis. We had one with histoplasma in his brain. We had one with Mycobacterium avium in his lungs. A lot of, well, syphilis is not a true AIDS-defining illness, but a lot of neurosyphilis. So I think COVID has had a bad impact in the early diagnosis of HIV. And now we're seeing patients that probably acquired this infection in 2019 or 2018. And for known reasons, didn't get healthcare, and now they're presenting with opportunistic infections. I'm sorry. I was saying Arthur Ashe was the tennis player who got HIV through a blood transfusion.
There was a question in the chat. Are you going to discuss the approach to counseling a patient on initial diagnosis on the next presentation?
Yes.
Okay. Do we have any other questions? Okay. Great. Well, thank you everybody for joining us today. Just a reminder to fill out the survey in the chat. Or the link is in the chat. It'll take you to a site to fill out the survey. And join us next month, which is April. And actually, it will be April 20th, not the 14th. We are having that clinical training, and we'll be traveling back from that. So we're going to be doing the 20th. And yes, I don't have anything else. You all have a great afternoon. Thank you all.